if you're looking for a story of, well, intellectual stubbornness, some really high-stakes surgical drama, and then eventual scientific triumph, you've definitely come to the right place today.
Absolutely.
Today, we are undertaking a deep dive into the historical evolution of breast cancer therapy. It's quite a journey, really.
Yeah.
Started with what was essentially a death sentence, and now, well, we're talking personalized, precision medicine.
It's arguably one of the most compelling narratives in the entire history of medicine. You're tracing thousands of years of human observation. And, what's often forgotten is just how ancient this disease really is,
Right.
and how long physicians struggled with it. Just resignation and frustration, really.
So our mission today is to trace this dramatic arc.
Yeah.
From those ancient physicians basically saying there's nothing we can do.
Yeah. Utility.
Through that really bloody, aggressive age of radical surgery, all the way to the modern, minimally invasive techniques we have now, which are only possible because we finally understand cancer systemically.
And we have to start really at the very beginning. We're talking around 5,000 years ago.
Wow.
The earliest known reference we have for breast cancer is found in the Smith Surgical Papyrus. This dates back to 3000 to 2500 BC.
So, okay, let's put that in context. We're talking about Egyptian medicine contemporary with the construction of the earliest pyramids. That's just incredible antiquity.
It really is. The papyrus documents 48 different case histories, and one of them describes this bulging tumor of the breast. And interestingly, it's in a man.
Huh.
Which sounds highly characteristic of cancer, even today. The description of the clinical features is surprisingly sharp. It notes how the growth would feel, cold and firm to the touch.
But then right after that clinical description comes this conclusion that just, well, it haunted medicine for centuries, didn't it?
Absolutely. After detailing the disease, the scribe's final statement, and it's chilling, was simply recorded as, "There is no treatment."
Wow.
And that just sets the definitive tone for the next few millennia. It's basically medical resignation in the face of breast cancer.
Okay, so we move out of ancient Egypt into the classical era. We're talking the 1st and 2nd centuries AD now. And Greek and Roman physicians start these first very tentative conversations about maybe operative intervention. So we're finally inching past total futility, but like you said, with enormous caution.
That caution is absolutely paramount. In the 1st century, you have the Roman encyclopedist Celsus. In his famous work, De Medicina, he makes this critical distinction. He notes that only the cacoethes, that's the earliest, most localized form of cancer, should ever be removed surgically.
And what was his thinking there? Why be so conservative?
Well, Celsus specifically warned that doing these aggressive operations on advanced cases, ulcerated or painful tumors, it didn't solve the problem. It only served to, in his words, irritate the rest of the disease. He essentially recognized, almost intuitively, that the visible tumor was connected to something bigger, something unseen, and that major surgery on an established tumor often just made things worse, accelerated the patient's death. It showed a kind of deep awareness of the limits of just cutting things out locally.
Then you get Galen in the 2nd century, the physician whose influence would just dominate Western medicine all the way up to the Renaissance. And he's the one who gives the disease its lasting name, right?
That's right. Galen described the tumor as resembling, a crab, carcinos in Greek, or cancer in Latin. He observed how the veins spreading out around the growth looked like the legs of a crab, kind of fixed to the body of the tumor.
That's such a vivid clinical description. But his actual therapeutic approach was still extremely guarded, wasn't it?
Yeah.
Sort of echoing Celsus.
Indeed. Galen agreed, yes, they could sometimes cure the disease in its very early stages. But he added that once the tumor reached a large size, quote, no one has cured it. He basically confirmed that widespread belief. If you could see advanced cancer, it meant the disease had already spread beyond the reach of the surgeon's knife.
Okay, so if they could see the problem, why did operative progress, the actual use of that surgical knife, why did it basically just stall for the next, 1,400 years? This is where that philosophical roadblock, the humoral theory, really clamped down hard on any kind of innovation.
This is absolutely the critical juncture. The entire Galenic system, which held sway for centuries, was built on the idea of the 4 humors, and cancer was attributed to an excess of black bile.
Yes, black bile.
A cold, heavy humor supposedly produced by the spleen. And crucially, this black bile wasn't seen as a local problem. It was believed to be a systemic imbalance. It basically poisoned the entire body.
Right. So if the disease was systemic from the get-go, if the whole body was just swimming in this malignant black bile, then cutting out a tumor on the breast was seen as, pointless, or maybe even harmful.
Exactly. Why remove a local manifestation if the systemic cause, the bad bile, would just create another tumor somewhere else? The theory didn't just suggest futility, it really implied a kind of philosophical defeat for surgeons.
Right.
And this intellectual dogma, backed by centuries of established wisdom, it was so powerful that very few dared to challenge it and push for local surgery until really the anatomical revolution of the Enlightenment.
But before we get fully to the Enlightenment, there was this kind of strange little detour in the 17th century.
Yeah, a brief one. In 1652, the Dutch anatomist Nicholas Tulp reported an instance that made him think cancer might actually be contagious. It was based on observing two women in the same house who both developed breast tumors. It was fascinating, but ultimately, incorrect. And our sources suggest that this idea of contagion, while pretty much dismissed by serious surgeons even then, it kind of lingered among some lay people well into the 20th century.
Okay, so now we arrive at the pivotal moment. The 18th century, the Age of Enlightenment. This is where anatomical understanding finally starts to provide a rational alternative to that old black bile theory.
The tide really turns with a French surgeon named Henri-François Dran. He's credited with fully repudiating the humoral pathology. He shifted the whole paradigm by recognizing that breast cancer wasn't just some static pool of black bile, it was a local disease that spread via a specific anatomical pathway.
Which was?
The lymph vessels.
That is a staggering breakthrough because suddenly he gave the surgeon something specific to actually chase down, something visible that could explain how the disease spread locally, the lymph nodes in the armpit, the axilla.
Precisely. Dran postulated that the cancer migrated from the primary tumor through these lymph vessels and then metastasized, setting up shop in the adjacent axillary lymph nodes. This replaced that really nebulous, systemic, philosophical theory with something concrete, anatomical, and, importantly, actionable.
And what was the immediate practical consequence of Dran's discovery? What did surgeons start doing differently?
He started routinely removing enlarged axillary lymph nodes during breast surgery. This single conceptual leap marks the true beginning of modern surgical oncology for breast cancer. Dran recognized that to achieve real local control, you needed a regional approach. You had to operate beyond just the visible tumor. And this laid the entire groundwork for the next major phase in our story, the Age of Radicalism.
Okay, so the 19th century grabs Dran's anatomical insight and just runs with it, scaling it up massively. It's driven by this core belief that the wider and deeper you cut, the better your chances of cure. This is truly the Age of Radicalism, focused intensely, almost obsessively, on total local eradication.
Right. And you have to remember, advances in anesthesia and antisepsis suddenly made these much longer, more destructive surgeries actually possible, survivable even. The goal became removing every single potential cancer cell that might have been contaminated by that primary tumor. In this early era, you see surgeons like Charles Moore in the mid-19th century really emphasizing complete breast resection and removing any lymph nodes in the axilla you could actually feel were enlarged.
But it was Mitchell Banks who really pushed that boundary further, wasn't it? Back in 1877, realizing that just feeling the nodes wasn't enough.
Yes, exactly. Banks advocated for removing the axillary nodes even if they weren't palpable, even if they felt normal. This is the concept known as prophylactic nodal dissection. He realized that occult involvement, basically disease hiding invisibly in the nodes, was incredibly common. That recognition of invisible spread was really the final intellectual piece needed for the creation of the monumental operation that would become the standard of care for the next 70 years or so.
And that, of course, is the radical mastectomy, codified by William Stewart Halsted at Johns Hopkins and William Meyer in New York around 1894. This procedure became the absolute definition of aggressive surgical oncology for breast cancer. Can you walk us through exactly what the Halstedian radical mastectomy entailed for the patient?
Oh, it was an absolutely uncompromising operation. It was driven by Halsted's specific pathology concept, which was that the disease spreads slowly and sequentially outward, kind of like a brush fire burning through the tissues, centrifugally. So, to achieve what he saw as total local regional control, the surgeon performed a complete unblock removal, meaning all in one piece of the entire breast.
Okay.
The underlying pectoralis major muscle, the big chest muscle,
Wow.
the pectoralis minor muscle beneath that, and a complete dissection of all the axillary lymph nodes, levels 1, 2, and 3, right up to the apex of the armpit.
That sounds utterly devastating to the patient's anatomy and function.
It was. To clear out the axilla that completely levels 1, 2, and 3 span from sort of the lower edge of the pec minor muscle deep beneath it and all the way up to the very top of the axilla near the collarbone, they routinely had to resect major structures. They would sacrifice the long thoracic nerve.
Which controls...
That controls the serratus anterior muscle, preventing the scapula, the shoulder blade, from winging out. And they often sacrifice the thoracodorsal neurovascular bundle, which supplies the latissimus dorsi muscle, a big muscle in the back important for arm movement.
So what kind of quality of life did that leave patients with after surgery?
Severe, often lifelong morbidity. Patients were left with this sunken, excavated defect on their chest wall where the muscles had been stripped away. They often suffered chronic nerve pain, significantly restricted shoulder movement, and critically debilitating lymphedema.
That's the arm swelling, right?
Exactly. Severe, lifelong swelling, heaviness, and pain in the arm on that side because all the lymphatic drainage channels had been completely removed. But, for the time, it did achieve the highest rates of local regional control seen to date, so it became the standard of care. The price, though, was absolutely body integrity and function.
So this aggressive doctrine held sway for a long time based on that belief. Cut wide enough, cut deep enough, and you could conquer the disease locally. But even this incredibly radical surgery eventually ran into its limits. And those limits were starkly defined by Hygenson and Stout in 1943.
Yes, they did landmark work at Columbia. They systematically defined the clinical signs that indicated when the disease had already spread beyond the reach of any local curative measure, no matter how radical the surgery. They were essentially trying to define the boundaries, the limits of the Halsted procedure itself.
And they called these the grave signs. What were they?
Things like significant edema or swelling of the skin of the breast, what we call peau d'orange, like orange peel skin. Also, skin ulceration, the tumor being fixed to the chest wall so it couldn't be moved, and massive fixed axillary lymph nodes, specifically defining them as larger than 2.5 centimeters.
And their data on outcomes for women with these signs was?
Extremely sobering. They found that women presenting with 2 or more of these grave signs had only a 2% 5-year disease-free survival rate after radical mastectomy.
2%. That's basically saying the disease was already systemic, the horse was out of the barn, and the radical operation was just causing misery without offering any real chance of cure. It was a formal acknowledgement that these women were, in their words, beyond cure by radical surgery. And that data really was the beginning of the end for the undisputed reign of the Halstedian dogma.
It absolutely forced surgeons to reconsider the value proposition. If a patient with advanced disease was almost certainly going to die from systemic spread anyway, why subject them to such a mutilating, morbid local operation? And this thinking paved the way for the first significant de-escalation in surgery, the modified radical mastectomy.
And this was pioneered by Patey and Dyson in London back in 1948. It marks a really significant step toward trying to preserve some function while still aiming for nodal clearance.
Exactly. The modified radical mastectomy, or MRM, involved removing the entire breast and still performing a complete axillary node dissection, levels 1, 2, and 3. But critically, they preserved the pectoralis major muscle.
Ah, okay, so the chest wall contour would be better.
Much better, and function too. They found they could still access all the lymph node levels adequately by removing the smaller pectoralis minor muscle. This allowed surgeons to maintain the superior bulk and function of the shoulder girdle while still achieving what was considered necessary nodal clearance at the time.
This feels like a subtle, but pretty profound shift in philosophy. They explicitly stated, didn't they, that a high proportion of advanced cases were essentially doomed to die unless an effective systemic agent was found.
It was an intellectual retreat, you could say, from the pure local control obsession. It was an acknowledgement that surgery locally had probably done all it could do for many patients. The real key to improving survival now lay elsewhere. It was time for medical science, things like radiation, and eventually chemotherapy and hormonal therapy to provide the real cure potential. And so by the 1970s, this less disfiguring and functionally superior modified radical mastectomy had largely replaced the Halsted radical as the standard operation, certainly in the United States.
Okay, so the stage is now set for the real revolution, kicking off in the 1970s. The modified radical is the standard, sure, but the underlying assumption is still kind of Halstedian that maximum local removal gives the best chance of survival. But clinical trials were about to fundamentally challenge that foundational belief, and this is where Bernard Fisher and the NSAB trials just completely changed the field.
Fisher's work was all about demanding evidence, running the big trials. The core question he posed was, Does the sheer extent of the local surgery, how much tissue you remove, actually impact long-term survival? Or is survival primarily dictated by what's happening systemically, by micrometastases that have already escaped?
Let's unpack that first blockbuster trial, NSABP-BZO4. This was conducted in the early 1970s. What did it compare?
BO4 was designed to directly compare the most aggressive surgery acceptable at the time, the Halsted radical mastectomy, against more limited approaches. They randomized women who were clinically node negative, meaning their armpit nodes felt normal, into 3 groups. Group 1 got the Halsted radical. Group 2 got a total mastectomy, just the breast removed, plus radiation to the chest wall and lymph node areas. And Group 3 got total mastectomy alone.
Wait a second. If BO4 showed that just removing the breast, the total mastectomy group offered the same survival as the full Halsted radical, didn't that immediately make every surgeon trained in the Halsted era question their entire life's work?
It created absolute seismic shock waves throughout the surgical community. The results, which held up even with long-term 25-year follow-up, were just undeniable. For these node-negative women, there were no significant differences in overall survival between the 3 groups. More aggressive regional surgery simply didn't improve long-term cure rates.
So this result essentially just pulverized that core Halstedian dogma of slow, sequential outward spread. If taking out the nodes and muscle didn't help survival, it strongly suggested the disease wasn't just spreading predictably like that brush fire.
Exactly right. And this finding birthed what became known as Fisher's alternative hypothesis. He proposed that breast cancer is often, perhaps usually, a systemic disease right from the moment of clinical diagnosis. Tumor cells gain early access to both the blood vessels and the lymphatic channels, maybe even simultaneously. In this model, the regional lymph nodes aren't really barriers that stop the disease. They're more like prognostic markers.
Indicators.
Indicators, exactly. Their involvement just tells you that systemic spread has likely already occurred. And therefore, aggressive local or regional surgery, once metastasis has already started, even microscopically, is unlikely to substantially impact the patient's ultimate survival.
Wow. That philosophical leap is huge because it directly paved the way for prioritizing function, appearance, quality of life. If we don't need to remove the whole breast and strip the chest wall to save the patient's life, then maybe the patient shouldn't have to lose the whole breast.
Precisely. We started moving away from the idea of curing solely by cutting more towards localized treatment aimed at controlling the breast disease, backed up by systemic therapies to handle the potential spread. And this brings us squarely to the birth of breast conservation. Now, it's worth mentioning that Geoffrey Keynes in the UK had reported early, successful results with breast-conserving surgery combined with radium implants way back in 1937.
Ahead of his time.
Way ahead. But it was really the definitive trial data from the NSABP that legitimized it and brought it into the mainstream.
And that definitive trial was NSABP B06. This was the massive study that formally compared lumpectomy to mastectomy and really cemented its place in the standard of care.
That's the one. B06 randomized over 1,800 patients into 3 arms. Total mastectomy, lumpectomy alone, just removing the tumor with the margin, and lumpectomy followed by breast irradiation or radiation therapy. And the results were just as revolutionary as B04's. First, confirming that systemic theory again, they found no difference in overall survival between the 3 groups, even after 2 decades of follow-up. Mastectomy did not save more lives than lumpectomy.
But the trial also showed the absolute critical necessity of one component of that conservation approach, right?
Yes. For local control within the breast itself, radiation was mandatory. The group that received lumpectomy alone, without radiation, had significantly higher rates of the cancer coming back in that same breast, local recurrence, compared to the group that got lumpectomy plus radiation. This confirmed that the conservative approach works beautifully, but only when the surgery, lumpectomy, is backed up by adjuvant radiation to essentially mop up any microscopic disease that might be left behind in the surrounding breast tissue. So, breast-conserving therapy lumpectomy plus radiation became the new gold standard for most women with early-stage breast cancer.
All right, so once the breast itself was being conserved, the next logical target for de-escalation had to be the axilla, the armpit that Regent Halsted had so brutally stripped clean. We needed a much more precise way to figure out if the lymph nodes were involved without resorting to that full, morbid dissection for everyone.
That clinical need directly drove the development and refinement of sentinel lymph node, SLN, dissection. The concept is elegant. The sentinel node is the first lymph node, or maybe the first couple of nodes, that drains lymph fluid directly from the tumor. So if the cancer is going to spread to the nodes, it should theoretically show up there first.
Like a guard at the gate.
Exactly. Pioneer work by surgeons like Don Morton initially for melanoma, and then Craig, Giuliano, and Veronese specifically for breast cancer, developed techniques using blue dye and/or a radioactive tracer injected near the tumor to identify and remove just these one or two sentinel nodes. The idea was if these key nodes are negative, the rest of the nodes in the axilla should also be negative, and you can spare the patient the full dissection.
This was potentially a massive quality of life victory, wasn't it? Because that full axillary lymph node dissection, the ALND, carried such a high risk of that chronic lymphedema and shoulder disability. What trial definitively proved that just taking out the sentinel nodes was sufficient if they were negative?
That was the landmark NSABP B32 trial. It directly compared women with clinically node-negative breast cancer who were randomized to either SLN dissection alone, if negative, or SLN dissection followed by a completion ALND regardless. It showed absolutely equivalent survival rates between the two groups. But crucially, the morbidity was drastically reduced in the SLN biopsy alone group. They had significantly less lymphedema, less pain, less numbness, and better arm function. It became the standard overnight for staging the axilla in clinically node-negative patients.
Okay, so B32 proved that if the sentinel node was negative, we could stop there. Huge step. But what about the patients where the sentinel node was positive? Maybe just one or two positive nodes. Do they still need the full ALND? Could we possibly spare even them the morbidity? I mean, that seems to fly in the face of centuries of surgical thinking. You find cancer in a node, you take out all the nodes.
It absolutely did, and that's precisely what makes the ACOSOGS 00-11 trial such a practice-changing, truly revolutionary piece of evidence. This trial focused on a very specific but common group of patients. Women with relatively small primary tumors, T1 or T2, who were having breast-conserving surgery, lumpectomy, followed by standard whole breast irradiation, WBI, and who were found to have only one or two positive sentinel lymph nodes. The huge question was, do these women actually benefit from having the remaining axillary nodes removed in a completion ALND?
And the finding was almost impossible for many old-school surgeons to believe at first, wasn't it?
The finding was profound and has held up over time. For these selected patients, the trial showed absolutely no difference in overall survival or disease-free survival between those who underwent the completion ALND and those who had no further axillary surgery after the positive sentinel node was found. Furthermore, the rate of the cancer actually recurring in the armpit nodes later was extremely low and statistically similar between the two groups, less than 1% in both.
So what was happening? How could leaving potentially positive nodes behind be okay?
The interpretation is that for these women with limited nodal disease, the combination of the tangential radiation fields used for whole breast irradiation, which incidentally treats the lower part of the axilla, and the systemic therapy, chemo or endocrine therapy, they were likely receiving anyway, was sufficient to effectively sterilize any small amount of residual cancer in the remaining lymph nodes. The additional surgery wasn't adding benefit, only harm.
Harm in terms of it.
Quality of life, mainly lymphedema. The Z00001 data was clear. The rate of clinical lymphedema in the group that got the full ALND was around 13%, whereas it was only about 2% in the group that just had the sentinel node biopsy. A massive difference. This trial has allowed hundreds of thousands of women worldwide with limited nodal involvement to safely avoid the devastating long-term side effects of a full axillary dissection. #tag integrating systemic therapies, the modern multidisciplinary approach.
And it's just so crucial to keep stating that this incredible surgical de-escalation we've traced, from radical mastectomy all the way down to lumpectomy, plus just sentinel node biopsy for many, it was only possible because we had increasingly effective systemic therapies running in parallel. The medical oncologist really became the key player in fighting the systemic part of the disease.
Absolutely. You cannot separate the surgical evolution from the pharmacological evolution. The conservative revolution is fundamentally underpinned by effective drugs. And the first truly great systemic breakthrough was endocrine therapy, particularly starting with tamoxifen in the 1970s and 80s.
What makes tamoxifen so effective, especially for those hormone receptor positive tumors, which are the majority?
Tamoxifen is what we call a selective estrogen receptor modulator, or SERM. In breast tissue, it basically gets into the estrogen receptor on the cancer cells and blocks estrogen from binding to it. Since many breast cancers rely on estrogen to grow, tamoxifen effectively starves them. Used as an adjuvant therapy, meaning after surgery, typically for 5 years, large clinical trials showed it reduced the risk of breast cancer recurrence and, importantly, reduced breast cancer mortality by about a third over 15 years of follow-up.
Wow.
And critically, studies showed it had a significant carryover effect. The benefit, the protection against recurrence and death, actually continued even after patients stopped taking the drug after 5 years.
And then for postmenopausal women, the standard endocrine therapy often shifted towards aromatase inhibitors, or AIs. Why are AIs generally preferred in that specific patient group?
Aromatase inhibitors work by a different mechanism. In postmenopausal women, the main source of circulating estrogen isn't the ovaries anymore. It's the conversion of androgens into estrogen in peripheral tissues like fat and muscle. This conversion is done by an enzyme called aromatase. AIs block this enzyme, drastically reducing the overall amount of estrogen available in the body to potentially feed the tumor. Large meta-analyses confirmed that for postmenopausal women, starting with an AI or switching to an AI after a few years of tamoxifen resulted in significantly lower recurrence rates and better survival compared to using tamoxifen alone for the full duration.
Okay, so we have powerful hormonal therapies, and then we reach the era of targeted treatments, the real precision medicine that has dramatically changed the outlook for specific, often more aggressive subsets of breast cancer. The big one here is HER2 positive disease.
That's probably the most dramatic example of targeted therapy success in breast cancer. About 15 to 20% of breast cancers overexpress a protein called HER2, which acts like a growth accelerator, making these cancers historically very aggressive with poor prognosis. The introduction of drugs like trastuzumab, which is a monoclonal antibody specifically designed to target and block the HER2 receptor, completely transformed the outlook for these patients. When trastuzumab was added to standard chemotherapy, it dramatically increased cure rates.
And we often see these powerful targeted therapies and chemotherapy, too, being used in the neoadjuvant setting, now meaning before surgery rather than after.
Yeah.
Why is that sequence change often so important?
Giving the systemic therapy first in the neoadjuvant setting has several advantages, especially for more aggressive subtypes like HER2 positive or triple negative breast cancer. First, it allows us to see in real time how effective the treatment is in vivo inside the patient's body. Does the tumor shrink? Second, shrinking a large tumor before surgery can sometimes make a patient who initially needed a mastectomy eligible for breast-conserving lumpectomy instead. Oh, okay.
But perhaps most importantly, achieving a pathologic complete response, or PCR, after neoadjuvant therapy has become a major goal and a strong prognostic indicator.
Can you explain for our listeners what exactly is a pathologic complete response, a PCR?
A PCR means that when the surgeon removes the breast tissue or the tumor bed after the patient has finished their neoadjuvant chemotherapy and ordered targeted therapy, the pathologist looks at it under the microscope and finds no residual invasive cancer remaining. All the invasive tumor cells have been killed by the preoperative treatment.
And that's a good sign.
That outcome, achieving a PCR, has been found to be highly predictive of excellent long-term disease-free survival and overall survival, particularly in those aggressive subtypes, HER2 positive and triple negative. In some of the key trials adding trastuzumab to chemotherapy for HER2 positive disease, the PCR rates just skyrocketed, going from maybe 25% with chemo alone up to over 65%, even close to 70% in some studies with the combination. That is just incredible, and it really highlights why the modern approach is such a team effort, isn't it? It's a multidisciplinary consensus. The surgeon provides the essential local control, the precise removal, but often it's the medical oncologist delivering the systemic cure, sometimes even before the patient gets to the operating room.
So looking back across these millennia, the trajectory is just almost unbelievable, isn't it? We started way back in antiquity with that stark, simple observation: there is no treatment.
Right. And then we spent, 1,400 years basically trapped by that philosophical belief in black bile until Dran finally used actual anatomy to justify the very first steps of focused surgical removal back in the 18th century.
And that breakthrough led, perhaps inevitably, to the aggressive, really uncompromising age of radicalism, where Hallstadian surgery reigned supreme for decades, offering, yes, better local control, but at a really severe cost in terms of patient function and body integrity.
And then came that truly revolutionary shift, driven by the rigorous clinical trials in the 1970s and beyond, spearheaded by people like Bernard Fisher. Trials that demonstrated convincingly that breast cancer is often fundamentally a systemic disease right from the start. And that understanding allowed us to pivot, finally, to the current much more conservative paradigm.
Exactly. The paradigm of lumpectomy plus radiation for breast conservation, precise axillary staging using sentinel lymph node dissection, and now even further de-escalation of axillary surgery for many patients with limited nodal involvement thanks to trials like ECOSOG Z0011.
And the payoff of challenging that historical dogma, of demanding evidence, is measured directly in lives saved and improved quality of life. The statistics are pretty stark. The 5-year overall survival rates for women diagnosed with breast cancer in the U.S. have dramatically improved from around 63% back in the early 1960s, which was really the peak Halstadian era, to nearly 90% for the most recent tracking periods.
It's a staggering improvement. And it really proves that scientific humility, that willingness to question even the most deeply entrenched surgical traditions, when combined with those powerful systemic drug breakthroughs, delivers truly tangible results for patients.
It does. And this continuous refinement, this history, it points to that crucial ongoing balance that's required in cancer therapy. Because while Fisher's alternative hypothesis rightly shifted the focus heavily towards systemic treatment being key for survival, our sources and current understanding remind us that local control dealing with the disease in the breast and nodes still remains critically important. It's not all about systemic therapy.
That's a vital point. Why is controlling the local disease still so important, even when we have these incredible targeted agents and chemotherapies?
Because local recurrence, the cancer coming back in the breast or nearby lymph nodes, isn't just a local nuisance. It still significantly increases the risk of the cancer then spreading distantly, metastasizing, and ultimately leading to death years down the line. There's compelling evidence for this. The huge overview analysis from the Early Breast Cancer Trialists Collaborative Group, the EBCTCG, pooling data from tens of thousands of women in trials.
Yes, massive studies.
They showed that effectively avoiding a local recurrence in the breast or chest wall translates directly into saving lives. Their estimate was that it avoids about 1 breast cancer death over the next 15 years for every 4 such recurrences avoided.
Right. So here's where it gets really interesting and maybe a bit counterintuitive after embracing the systemic view for so long. This finding confirms that while systemic therapy is crucial for tackling micrometastases, the localized tumor mass itself, if left uncontrolled or allowed to recur, still holds significant metastatic potential. For at least some proportion of cancers, the local disease remains the engine driving future systemic failure. It's not purely one or the other.
So the history of breast cancer therapy really is this ongoing lesson in continuous optimization, isn't it? Finding that sweet spot.
Exactly. And the question, really, for the next generation of research is how we refine this multidisciplinary approach even further. How do we get even smarter? It's not just about identifying which tumors need which systemic agents based on their biology, which we're getting much better at, but maybe also identifying which specific patients, perhaps guided by tumor biology or response to initial therapy, might be able to safely forego certain components of local treatment altogether, like maybe skipping radiation after lumpectomy in very low-risk cases, or even de-escalating surgery further, always seeking that perfect balance between maximizing the chance of cure and minimizing the treatment burden, maximizing long-term quality of life. That's the ongoing challenge.